to remind you folks about the student accessibility service. If you have accommodation, you have to enroll yourself, or like you have to let them know that you're going to use the accommodation, and that's how you get to know that you'll be in accommodation, right? So just a reminder, if you have an accommodation, please go through this. Okay, I'm getting lots of questions regarding midterm. One of the questions this morning was how many questions are going to be there from cell and how much are going to be from the cardiovascular. It's hard to say. I would say 30-70. At least 30% of questions are coming from cell. I don't know how to put this in words, but the online module is so very important for both parts of cell and TV. But I'm covering most of the part in the lecture from cardiovascular. So the cell is mostly the online module and your books. Please make sure that you take notes while you are preparing for your cell, because line by line, make sure you have notes. Anions, cations, or cell membrane, whatever things are there, make notes. The questions are coming from this online module regarding this, okay? And for the cardiorespiratory, you have some coming from the cardiovascular lectures, and there is an overlap of lecture on the online module, so you won't find something completely different in your online module. So I cannot reinforce how much the lecture materials are important. Make sure you prepare accordingly, right? If you have any questions in the lecture material during the class, stop me and I'm happy to go over it. Yeah.
Are you allowed to tell us how many total questions there are?
I think there are, I don't know exact number of it, but are mostly MCQs. At the very end, you will have 2 mark questions, also 4 mark questions. You may have to write 3 out of 5. So you'll have 5 questions. You'll have a choice of picking up any 3 and strike out the ones that you're not attending. So we don't, if you do, then there are instructions, I think, at the top. So if you do all the 5, I've been asked to mark only the first 3 and strike out the last 2. So you can choose which one you want to address, and then you can strike out the ones that you don't want to. Yeah, so yeah, for the midterm. It's a 1 hour exam, so it's not a lot. So I think like you can do it.
Yeah.
Yeah, thank you. So some definitions are important in the cardiovascular. I'm not allowed to give you direct hints, so make sure the definitions are important. Yeah. As we go along, I might point out something, say like, oh, this seems like important. Maybe that's important. Okay? Right? Any questions regarding midterm? So the midterm exam is going to be in Canadian Martyrs. I'll remind you folks next week where the location is, how to enter, all those big pictures. So that should help, I guess. And meanwhile, if you have any questions, feel free to ask me, stop me. We'll have a break in between the lectures. And at the end of the lecture, grab me anytime. I'm happy to answer any of your questions. Good? Shall we continue? Okay, last week we were talking about the cardiac output, right? Can you define cardiac output? I mean, like we were briefly talking about it. Okay, cardiac output is the amount of blood that is ejected from the ventricle. Cardiac output is the amount of blood. Okay, so I'm going to ask you, what is cardiac cycle?
Like the lift of the heart, yes. And like the cycle which it contracts and relaxes.
Exactly. So it's a series of events that is happening per beat. It's a cardiac cycle. So series of events that is happening per beat is a cardiac cycle. And cardiac output is the amount of blood that is ejected from the ventricle. How do we calculate cardiac output? We have a formula for that. The stroke volume times heart rate. So last week we talked about how to calculate the stroke volume. Right? The stroke volume can be calculated using end diastolic volume, subtracting end systolic volume. So what is end diastolic volume? We will be going through this again, but still, end diastolic volume is amount of blood that is going to be in the heart after the atrial contraction or before the ventricle is going to contract. So amount of blood that's going to be in the ventricle when the ventricle is in the diastolic. So that's the end diastolic volume. So we said is approximately 120 ml. So end systolic volume would be the amount of blood that is retaining in the ventricles after the contraction or the systole. So it's going to be approximately 50 ml. So the stroke volume is going to be approximately 70 ml. Okay. So this is how we calculate the stroke volume. And yeah. So let's see. I had a wonderful question last week. If this cardiac output is going to be changed, if the heart rate is going to be different, so I'm going to explain how that's going to change. So there are factors that influences the heart rate. I'm going to go slow. If you find it difficult to follow, just stop me, okay? So there are factors that's going to influence the heart rate. There will be factors that's going to influence the stroke volume. So let's begin with the heart rate. So before that, I'm going to ask you the same question that you asked me last week, but in a different tone. Let's say this is going to be my cardiac output. Let's say 5 liters or 4.3 liters because I'm just doing nothing, just standing here. But say if there's going to be a threat, I have to run out of this door. How my cardiac output is going to be different?
Just the heart rate's going to go up.
Yes, the heart rate goes up. Yes. Yes. The cardiac output is what's yours?
No.
That's the same. Okay, the cardiac output is going to increase because the heart rate is raised. But is that the same thing with tachycardia?
No.
Why not? Exactly. So in tachycardia, it's happening really, really fast, and there's no enough time for the ventricle to relax or diastole to happen, and that's why. So sometimes the tachycardia happens even without any exercise. So one important factor that is going to improve the cardiac output is your venous return. Say like I'm running, I'm exercising, or I'm running to catch a bus. So I'm running, so my calf muscles are going to move all those blood into my atrium, right atrium. So then my heart rate is higher. So they say in a non-athletic adult, if they are running but they are non-athletic, their cardiac output could be 25 liters to 30 liters, or 20 to 25 liters, approximately. If they are non-athletic, if there's a person who is really athletic, been exercising for so long, their cardiac output can be 30 to 35 liters, based on their physical ability. Why is that different?
Sorry, I just couldn't see. Thank you.
Why is that different? For an athlete,
because in somebody that's athletic, body is already used to activity.
yes, that's part of it. Yes. What part of it train? Muscles, including cardiac muscles. So the myocardium is really, really strong, so it is able to pump. The contractility of the heart, which we are going to discuss in a minute, the contractility is going to be good, their end diastolic volume is going to be good, and their end systolic volume is going to be low. So that increases their cardiac output 7 to 8 times than the resting cardiac output. So how do we calculate the cardiac reserve? Is cardiac output max minus cardiac output at rest. So that would be the cardiac reserve. So let's say my cardiac max is 17, and the cardiac at rest would be 1.5, let's say. What I should see my cardiac reserve. This much I can go without getting into trouble. So my heart can handle this much. So that's how we calculate the cardiac reserve. Cardiac max minus the cardiac output at rest. Is it clear so far? So now I'm going to go into the factors that is going to influence the. I'm going to write it here, so I'll be using that.
Yes, like fancy.
Right? Okay. So I want you folks to let me know when our heart rate would be increased. In what occasion? Say like what influences the heart rate? Okay, exercise, yes.
Types of life.
Perfect. So sympathetic response. So in the sympathetic response, heart is innervated by the sympathetic nerve. So it releases norepinephrine or epinephrine, acting on the beta-1 adrenergic receptors on the heart, which would be increasing the heart rate. Alright, what else? If there is going to be exercise, if there is going to be a sympathetic response, so the epinephrine or norepinephrine would be acting on the beta-1 adrenergic receptors of the heart, which increases the heart rate. Is there anything else that can increase the heart rate? Stress. Yeah, stress. So which again would be similar to the sympathetic response? Anything else?
That's the physiological.
Yeah, tachy would be a pathological condition. So also uses.
Hypertension.
Yeah, arrhythmias. But it is not rhythmical, but it's an increased heart rate itself. So in the sympathetic response, heart is innervated by the sympathetic nerve. So it releases norepinephrine or epinephrine. It will be acting on the beta-1 adrenergic receptors on the heart, which would be increasing the heart rate. Alright, what else? If there is going to be exercise, if there is going to be a sympathetic response, so the epinephrine or norepinephrine will be acting on the beta-1 adrenergic receptors of the heart, which increases the heart rate. Is there anything else that can increase the heart rate?
Stress.
Yeah, stress. So which again would be similar to the sympathetic response? Anything else?
That's the physiological.
Yeah, tachy would be a pathological condition. So tachy also increases.
Hypertension.
Yeah, arrhythmias. But it is not rhythmical, but it's an increased heart rate itself. And there's another one, important one, so the hormones, thyroxine. The thyroxine can increase the metabolism. So when it increases the metabolism, increases the heat, which again would be increasing the heart rate. So that's why in exercise you have the increased heart rate, because the body's temperature is rising and the venous rhythm is improving. That's one of the reasons you have an increased heart rate. And opposite is true. If there is cold, your heart rate goes down. Alright? Anything else I'm missing? Yeah?
Low blood volume.
Low blood volume. Can you explain how that's going to increase the heart rate?
Like if someone is hypotensive or
If they are hypotensive, you mean the heart rate goes up?
yeah.
Okay. Yes?
I think like to compensate
Yes.
the low volume.
Okay. So even in the if there is increased carbon dioxide in the body, it increases the heart rate. So increased carbon dioxide and increased or acidity or acidosis. And there is an interesting for atrial vein bridge. So atrial vein bridge reflex is nothing but increase in venous return comes to the atria or the right atria. The right atria accommodates, it expands to accommodate it. So once it, when it enlarges to accommodate it, the SA node, it gets triggered. So once the SA node gets triggered, it will be increasing the heart rate. Which is called as the atrial vein bridge reflex. And to answer the question how the blood pressure, the volume in the blood influences, we have the chemoreceptors and baroreceptors. In the body, especially in the arch of aorta, we have the chemoreceptors or the baroreceptors. Chemoreceptors would be sensitive for the carbon dioxide levels in the body, whereas the baroreceptors would be sensitive for the pressure difference in the body, and based on that, it will be increasing the heart rate. If there is increased carbon dioxide, it's not actually influencing directly on the heart, it's going to influence the respiratory center in the medulla to increase the respiratory rate. once increased respiratory rates will trigger the heart rate to be increased. So that's how it is related, not directly, but it's going to be increasing the heart rate eventually. So what are the factors that's going to decrease the heart rate?
Like when you're exposed to like cold, like the what is the primordial reflex or something?
You mean the hypothermia?
No, like they have you like put your head in like a cold bowl of water and it drops your heart rate because of the diving reflex.
That's one way to artificially put it, but how body actually naturally reduces the heart rate. So whenever there is a sympathetic response, there will be a parasympathetic response.
Fighting of flight.
Yeah, that will be followed by parasympathetic.
Yes, the
So
opposite.
it releases acetylcholine, which will be acting on the muscarinic receptors to decrease the heart rate. And then the cold or decrease the temperature. Sleep would be the rest. Your heart rate would be normal, right? So that's how. Yes, and the ions. Yes.
No, let's just go back to acetylcholine for a second. You said it affects the muscles. Is that just the heart muscles or is it like all muscles?
All muscles, they have the muscarinic receptors. I think those receptors is found in all the muscles. That's why we have increased heart rate and then decreases. We have a system from the medulla, it releases the acetylcholine through the muscarinic receptors. Okay. And we missed an important word, the ions. Here, if there is going to be increased calcium ion, it will be increasing the heart rate, whereas potassium will be decreasing the heart rate. Are you folks familiar with the MAID program? Yeah, so do you know what the medication they give? Potassium chloride. So it is going to decrease the heart rate or stop the heart. So potassium, if there is going to be increased or decreased potassium, hyperkalemia, hypokalemia, that is going to affect the heart rate. Not to complete stop or to decrease the heart rate. So let's. All right. Is it clear? Any questions so far? Okay. Now we looked at one of the component heart rate, how it's been influenced by. I'm going to go into the stroke volume. I'm going to erase it so this is straight. Okay. Okay. So the stroke volume can be influenced by three important factors. One is preload, the other one is contractility, and the third one is afterload. This is super easy, okay? So preload, what is preload? As we talked, preload is the amount ventricles can stretch to contain the blood. So imagine we have a balloon and it has got, it might be having so much extensibility or can stretch, but if the optimal length where you can blow is preload. So you cannot blow too much, but an optimal level which it can be filled is preload. Contractility is the cardiac cell. The contractile force or the contractile strength of the cardiac muscle is contractility. Afterload is the amount of pressure exerted by the arteries. Let's say whoever is in the hallway or the arteries, right? And I have to push the door against them. Imagine they are pushing the door from there. I have to push them from here to open the door. The force exerted on the door would be the afterload. So if there is going to be increased pressure in the arteries, I have to be exerting more pressure to open the door. So that would be the afterload. The back pressure exerted by the blood in the large arteries leaving the heart. So we will go through one by one. Okay, preload. explain what is preload again in your own words? Containing the blood, yes. Okay, you know next. So what are the factors that can influence the preload? So we know that amount of blood that coming into the ventricles is important for the preload. The more the blood coming in, it's more it's going to stretch. And we need that to have a good contractility and then to have a good stroke volume. So what can influence a good preload? Increased venous return. Say like if I'm exercising, so I'm working out all the muscles and the venous, we store blood in our veins because the veins has got valves and most of the blood is stored in the veins. If you don't exercise, all those blood is going to be there. That's why when you exercise, when you work out the heart muscles, the blood stored in the muscles is going to come back as a venous return. So if there is going to be an increase in venous return, that's going to influence the preload. And what else? And the amount of stretch in the muscles, the cardiac muscle is also going to influence the preload. So we have a law known as the Frank. So his law can be applied on the preload and the contractility. So he says if the muscles are stretched to an optimal length, then it is going to do a really good contraction in simple words. So I'll be showing you the law in a minute. So increase the optimal length of fiber, say there's more actin and myosin bridges, then that is going to be a good contraction. For that to happen, you have to have a good preload or kind of end diastolic volume to be there. So as per the definition, the more muscle is stretched, the greater the force of contraction. With more blood, more force of contraction results within limits because we cannot stretch the heart muscles too much. Anatomically, it's not going to allow it because we have the fibrous membrane that is the fibrous layer that's protecting the heart, which won't allow it to stretch too far. But if, say, like if there is going to be a left heart failure or left heart hypertrophy or right heart hypertrophy, it's stretched, but it's not going to contract really effectively because there's going to be pooling of blood. It's literally losing its elasticity. So we need an optimal contraction within limits and more blood coming in, so the more force of contraction. And it has got its effect on preload. So the next topic is contractility. So again, I'm just going to repeat myself. Contractility in other ways is known as the amount of contractile strength of the heart muscles to effectively contract. So what can influence an effective contraction is the calcium in the extracellular fluid or getting into the cell and making more actin and myosin bridges, then it will be creating a good contraction. And is there anything else that can increase the contraction of the heart? We call it as the positive inotropic agents, and there are some negative inotropic agents which can influence the contractility of the heart. One is calcium. The other one would be thyroxine hormone. We said like it's going to increase the heart rate, right? So in that way, it is also going to increase the contractility of the heart. And the epinephrine or non-epinephrine or the sympathetic response. And some drugs like digitalis will increase the contractility of the heart. What would be the negative one? The negative one we talked about was the potassium. And what would affect the contractility of the heart if say like the muscles are damaged, the cardiac muscles are damaged? In the case of myocardial infarction, is there any other condition you can think of that the muscles are going to, cardiac muscles are going to be?
A stroke or a fall that prevents oxygen from getting to the muscles.
MI, yeah. Anything other than MI? Or any sorts of damage into the cardiac muscles, yes?
Heart failure.
Yeah, heart failure, absolutely. So those two things, like anything that is damaging the myocardium would be affecting the contractility of the heart. And if there's going to be hypoxia or hypercapnia, which we talked about was increased carbon dioxide, decreased oxygen levels. And even say like digitalis is going to increase the heart rate. We have another drug called calcium channel blockers for the high blood pressure, would be decreasing the heart rate. So we talked about two things, right? If there is going to be increased preload, that would positively impact the cardiac output. Say like there is an increased preload, we have more stroke volume. If there is increased contractility, there will be more stroke volume. The only thing that is inversely proportional into the equation or inversely affecting the stroke volume is the active load. Do you know why? The afterload is the amount of blood that is going to be remaining in the heart. Let's think about this way. Afterload is the resistance that is the heart has to work against the arteries. Let's say this is the arch of aorta, and that's the ventricles, and there are arteries. So these arteries would be exerting pressure, let's say 80 ml per G. And the left ventricle has to pump around 20 ml per G to open this door. So this is afterload. Let's say if this peripheral resistance or the systemic resistance is going to be higher, because there's going to be atherosclerosis in the muscles, or there's going to be aortic stenosis in the valve, or there is any occlusion in the aorta, this might go up. And the heart has to work even higher on 80, let's say 200, in order to open this semilunar valve. So the pressure, the ventricle has to work against the pressure that is exerted by the arteries or called afterload. Is that clear? So let's say if there is going to be higher afterload, because our heart has to pump quite a lot, then there is going to be more blood pooling in, because it can only pump so much, right? It is not going to allow it to empty fully. So the ventricles is going to have some retained blood in there. If there is going to be retained blood there, the stroke volume is not going to be 70 ml. It's going to be less than that. So it's going to be negatively affecting stroke volume. If there is going to be a less afterload, for athletes who are working so much, their afterload is going to be so low, because their myocardium is so strong, it can pump so much blood out of their ventricles. So there is going to be less afterload, then that can improve the stroke volume. If there is going to be more afterload, then it's going to negatively impact the stroke volume. Is that clear? These two things, if there is increased preload, will positively affect the stroke volume. If there is increased contractility, that means the myocardium is so strong, it can positively impact the stroke volume. If there is going to be increased afterload, that means there is going to be more blood contained in the ventricles. That's not good for the stroke volume. We need a less afterload in order to positively impact the stroke volume. Is that clear? Any questions? Yeah? Why do you want me to go over? You want to know how the preload and afterload affect the stroke volume? Okay, preload is the amount of blood that is coming into the ventricles. Let's say this is the ventricle. Is how much blood it can take is preload. The amount of blood in ventricles. Yeah?
So maybe it's the pre that's confusing me. I thought that the pre is before it gets.
Oh, the pre is, they say preload because before the ventricles contract, how much the ventricles can carry. Let's say, imagine you have a bucket and you're pouring water into the bucket. That's preload. If I pour the water into the let's say a field, that's not preload. Before you fill in the bucket, how much the bucket can handle? Say like bucket can handle 4 liters of water. Before you pour it out, how much the bucket can handle is the preload. So your bucket can handle more, that is good for the stroke volume, because if your bucket can handle only, let's say 1 liters, but you have an entire field to water, but you have only 1 liter. That is not good, right? So you need to have more preload to have a good stroke volume, because this stroke volume is the one that is feeding all the tissues, brain, organs, and every beat, right? So we need more blood to supply for the entire body. The more preload is good. Preload is nothing but you're filling in the bucket, right? And the contractility is how much you say that you have an elastic bucket. So if you pour water, then it just gets widened. But you need the good, if you cannot just wrap up, it needs to have its position approximately in its proper shape, and has to expand it accordingly, then you will have a good stroke volume. If it just flaps out, you cannot really pour it out fully, because it's going to be empty. After load, it's like you say like you're having a full bucket, you want to pour it out, but there is resistance, there is a spot in between. The water is not going through, it just stays in your bucket. So you cannot water the entire field, right? So then you need to have less afterload. You have to empty the bucket. If there's more water retaining in the bucket, that means increased afterload, which is not good for the stroke. Okay? Any questions so far? Oh. Okay, so this can summarize how exercise can influence your stroke volume and heart rate and influence your cardiac output. Take a moment to look into the video. So far we talked about all of these ones. So you have exercise, which can increase your sympathetic activity, and the skeletal muscles are working harder, and the respiratory system is working. So, and then the increase the ventricular filling time due to, let's go with this one, exercise, increase the venous return, so increases the preload, and increases the stroke volume, and increases the cardiac output. So in an athletic person, a ventricular filling time is going to be more, but the heart rate is going to be low. I don't know whether I talked about it. Say like if I'm going to be running, and say like I'm not an athlete, but I'm running on a treadmill, my heart rate can go up to 180, 190. But if I'm a runner by background, so I've been running every day, if I'm running in a treadmill, my heart rate will be approximately 85 to 95. It's not going to go to the maximum heart rate because their heart or the myocardium is really trained. So their ventricular filling time is going to be really more because the heart is able to go for diastole, their heart is not pumping so fast, but they are doing the same workload, the venous return is coming back. So the ventricular filling time is increased, but the heart rate is reduced because they are really good athletes. And then the venous return is coming back, that increases the preload, that increases the stroke volume, and positively increases the cardiac output. Let's say somebody's taking epinephrine, thyroxine, or there is going to be excess calcium, which increases the contractility, because calcium, we will talk about it in a minute, is important for the actin and myosin binding. So that is going to increase the contractility or the muscle contraction, which would decrease the ESV or the end systolic volume, which we talked about, or the afterload. There's going to be less blood going to be retained in the ventricles after the contraction, which again going to increase because there's more pumped out, less retained, so increase the stroke volume and cardiac output. And then if there is CNS output in response to exercise like fright, anxiety, or decrease the blood pressure. So this is where we talked about the blood pressure. It's going to increase the sympathetic activity, and then once the sympathetic activity is increased, the contractility is going to be increased, and ESV is going to be dropping, stroke volume increased, and increases the cardiac output. When there is a parasympathetic activity kicks in, it says increase heart rate. It's actually going to decrease the heart rate, but ventricular filling is going to be increased, then increases the cardiac output. Right? Any questions so far? We will be going on to the circulation now. I am happy to take questions so far. No questions? Can I move on? Because heart circulation, so coronary circulation is nothing but circulation of heart. This is the shortest circuit because heart is supplying blood to the heart. That's so simple. So heart gives blood to the heart. It's coronary circulation. Right? Is that very simple? But one important thing to remember about the coronary circulation is only during your ventricular diastole, the heart will be getting the blood. I'm repeating it. Only during ventricular diastole, the heart will be getting the blood. I'll explain to you why in a minute. So what are the functions of coronary circulation? So it is the smallest circulation. It supplies blood to the heart. Why heart needs so much blood? It actually weighs 1/200th of the body weight, but it receives 1/20th of the blood supply. So it needs lots of blood supply because it's the only organ that is working day and night, even the lungs, without asking us to do it. If it's under our control, we'll be doing it off and on to each one, but it just works. It needs lots of oxygen, lots of nutrients to keep the muscles active. So it needs lots of blood supply. So it receives almost 1/20th of the blood supply. And in order to provide blood, it has got to make lots of anastomosis. Anastomosis is nothing but a network of blood vessels will be there to supply the heart muscles or the myocardium. And so those are the key function is to supply blood to the heart continuously. If it stops for a minute, then we will end up with myocardial infarction. So we need blood to the heart all the time. And we'll be talking about arterial supply and venous supply in a minute. So the arterial supply would be affected by certain things like increased heart rate, blood pressure, or if there's going to be arrhythmias and circulatory or the venous load. All those things going to affect the arterial supply. So that's in a brief term, and we're going to dig deeper into it. So one interesting thing about the heart is it receives blood only during the ventricular diastole. So I'm just going to show you how it happens. So we know in the aorta there is a semilunar valve which has got three cusps. Okay. So this is a cut section from we are looking the aorta from above. Okay. So from here we are looking at this semilunar, but from the top it has got three cusps. So we have this coronary artery coming out on either side of the coronary sinus or the aortic sinus, just above the valves. We have two coronary circulation or the coronary arteries. This is the right coronary, left coronary artery. So let's say the blood is pumped during the ventricular systole. The ventricle is contracting. The blood is going through. This is opening up. This is going to go through the aorta. But when the ventricles are relaxing, we talked about the backward pressure and then the blood coming back. Once this is relaxed, the blood coming back goes into these two arteries supplying the heart. So why it is not pumping out during the contraction is because the heart has got epicardial arteries and endocardial arteries. And let's see. This is the myocardium. So the arteries should be lying down laying on the top of the heart. So that's the epicardial arteries. And there is endocardial arteries because they enter through the myocardium. And they create a small plexus and they join together. That's how they are supplying the myocardium. This is the epicardial artery. This is the endocardial artery. So when the heart is going on a contraction, imagine when it is contracting, the muscles are contracting, right? When the muscles are contracting, these vessels are going to shrink. When the muscles are relaxing, the vessels are going to relax. That's how they get their myocardial blood supply. So they get their blood supply because of two reasons during the diastole. Because during the contraction, this is closed. only during the relaxation the blood comes back to the aorta and then gets into the right and the left coronary artery. In the myocardium, the muscles are really contracted and the vessels are really shrink during contraction. During relaxation, it is relaxed and they get the more blood supply. I think I have a picture. Okay, before the picture, this is how they get the blood supply in a graph. So during a systole or a contraction, you have less blood supply for the myocardium or the heart. But during diastole, you can see that there is a spike of blood supply in the heart. So in this picture, you can see during a systole, and this is during diastole. During the systole, you can see the epicardial blood vessels of the coronary artery, and this is the endocardium. You can see the plexus inside those two arteries. And during the muscle contraction, all these tiny capillaries are really thin or contracted. While during relaxation, these intramyocardial coronary vessels are relaxed, and that's how it gives lots of diffusion to the cardiac muscles. And this is how those epicardial coronary arteries, those endocardial artery plexus. When we say plexus, there are lots of capillaries joined together form a really complex network. It's called plexus, and that's how they are. These are tiny capillaries that supplying the myocardium or the cardiac muscles. And there is anastomosis. We talked about anastomosis, right? So I'll talk about how they do all these things because they go and join with the other artery and they make a little network. It's a really complex network, and that's how they supply the myocardium. Okay. So this is really important. I will not emphasize how important it is to remember all the branches of the arteries. To make it easier, I'm going to give you a flow chart. So it will be easier to recall it. A flow chart. Rather than a picture, I guess. Yes. Okay. Okay, follow this story. If you don't understand or if you couldn't follow it, I'm happy to repeat myself. So let's start from the left ventricle. Because we are talking about the coronary circulation, we need oxygenated blood. So I start from the left ventricle. From the left ventricle, the blood goes into the aorta. From the aorta, just above the segmental valves. Okay, I'm just going to reinforce this. The aorta has got two sinuses, not just one. Two aortic sinus. From each sinus there will be one artery coming out. It's not from one sinus, two branches out. It's from two different sinuses, right and left comes out. Okay? So let's say this is a right coronary sinus and this is the left coronary sinus. Coronary arteries here. So coronary artery is further divided into two, marginal and posterior interventricular artery. Okay, so the right coronary artery exists from the aorta, passes between the atrium and the pulmonary trunk. It just descends downwards. That's the right coronary artery. It just descends down and then it branches out into right marginal artery. And you can't see the posterior interventricular arteries because it just runs posterior to the ventricles and supplies the posterior part of the ventricles, right? So the marginal artery is also called as an acute artery because acute marginal artery because you can see the acute angle it's forming from here to here. There is an acute angle, so called as an acute marginal artery. And the posterior interventricular artery is so important because it supplies most of the posterior part of the ventricles. And also it supplies the SA node, the AD node. So this is really, really important. Because posterior interventricular artery supplies the SA node and AD node. So if this right coronary artery gives branches to the posterior interventricular artery, it is called as a right dominance. This is for your information. If the left coronary artery gives out a branch and makes a posterior interventricular artery, then we call it as a left dominance. There are cases where in people we see both the left and right coronary arteries will join together and form a posterior interventricular artery. Then it is called as co-dominance. So most of the people, 80% will have right dominance, where the right coronary artery will be giving out a branch called posterior interventricular artery. For the exam purposes, let's keep it this way. So the right coronary artery gives branches as posterior interventricular artery and marginal artery. Okay. On the left, it gives to the complex artery. And to keep it easier, let's say posterior. This is anterior interventricular artery. And this has got another name called as LAD, probably known as LAD. Left anterior descending on that. In this one, you can see there is a circumflex artery on the top. It just covers the left atrium, and then there is a left anterior descending artery or the anterior interventricular artery. It supplies most of the anterior part of the heart, and especially the ventricles. And this LAD is called as a widowmaker because most of the occlusions happen in the anterior interventricular or the left anterior descending LAD. So people, the clinicians used to call it as a widowmaker because most occlusions happen there. And there is another branch that gives out. The LAD gives out a branch called as the diagonal. I'll go over it.
So what are we talking about? What are we talking about?
Yes, coronary circulation. This is how the blood is supplied to the heart. It's easy to follow. So from the aorta, that's where we get all the oxygenated blood to the body, right? So even the heart gets oxygenated blood through the aorta. And the aorta gets blood supplied through two coronary arteries that's coming out of once the aorta is arching out, right? So and they have the semiluna valves here. Just above the semiluna valve, there will be two branches. We call it as the coronary sinus or aortic sinus. So those two on the right and the left coronary artery. The right coronary artery, as soon as it's descending down, it gives two branches, marginal and posterior interventricular. Marginal is also called as an acute marginal because of the acute angle it's there. So it's called marginal and posterior interventricular. We call it posterior because it's supplies the posterior part of the heart, right? And then the left coronary artery has got anterior. So when we have posterior, we need to have anterior, isn't it? So we have an anterior interventricular artery. It has got another name called left anterior descending or LAD for short. And this gives out a branch called diagonals. And the circumflex artery and the anterior interventricular. Two main branches, and the two main branches gives out a short obtuse marginals. And this one is like diagonals. You know how they form these anastomosis? The posterior interventricular artery, which is going at the posterior part, and there is an anterior interventricular artery. At the apex of the heart, they just join together. So that's how they work. Just like that, all these arteries are connected together, form the anastomosis, so that they have lots of capillaries and lots of blood supply. And the veins are so easy because they're nothing but all these arteries would drain into a vein. We have one good name for the vein is the great cardiac vein, which drains this one. And then it's this small vein, small cardiac vein. Middle cardiac vein. all these veins will drain into coronary sinus. Which drains into right atrium. So the story starts from the left ventricle and ends in the right atrium. That's it. So you don't have to, you can remember all the ways, but the great cardiac vein is the one we mostly talk about because that's the largest vein. You have another picture. So all the veins would follow the same course as the arteries. In the picture you can see the veins will just follow the same pathway as the same artery, and then they will drain into the coronary sinus, and the coronary sinus enters into the right atrium. That's it, folks. Circulation done. And I'm gonna ask you two other questions. Okay, see, the great cardiac veins, the great cardiac veins, and that would be entering into the coronary sinus. With the small, middle, I think I've covered most of this. So it follows the same course as the arteries. In this picture you can see, you cannot even see which is vein in the artery because they are all with the same, they follow the same course, but they drain from the myocardium and then into the cardiac sinus.
Yeah, I just want to see where the posterior vein is on here. Like, you see the anterior cardiac vein.
In this picture, they don't show
They don't show it,
post,
okay.
they don't show it. Maybe let's see in this one. Do you see the posterior cardiac? No, I don't see it. So they more talk about the anterior cardiac vein, small cardiac vein, especially they talk more about the great cardiac vein. The rest of the veins are so small and they don't really talk about it. You have a question, yes?
So the coronary sinus would be on it's connected to the right atrium directly.
Yes, yes. So let's say this is the right ventricle. So this is the superior ventricle and inferior ventricle. There is a coronary sinus here. So all these the veins will be drained into the coronary sinus. We don't have a picture. I think that clearly shows the coronary sinus. I think this is on the posterior aspect of the wall, I guess. So that's why it's on the anterior view doesn't show it.
Yes, she wrote above the seminal valve. Above the one in the bracket, right? Above the seminal valve.
Okay, so anastomosis. So I was talking about how these vessels attach to the another one, so communicate with another one. So let's say this is the anterior descending, let's assume that's the posterior ascending, descending. So they all join together with tiny capillaries. You know why they're doing it? Because say like if there is going to be occlusion in this artery, this area will be supplied by the other artery. So they are well prepared. Just in case if there is going to be a roadblock, you have a vein there. So with the venous rhythm, they have lots of anastomosis. It has got a clinical significance. Okay. Which statement is true about the coronary arteries? Does the coronary artery carry blood to the fibrous pericardium? Or the coronary artery blood flow is the fastest or the fastest contraction? Or the heart rate does not affect the blood flow of the heart? Or option B, coronary angiogram identifies anomalies in the blood flow around the heart. If you know the answer, just put your hands up.
It's D.
We got one answer D. D or A? A. The coronary artery blood flow is fastest or the fastest?
Is it when it's like relaxing?
No. You're saying the answer, but you're not very confident in what
I'm
you're
not.
saying. No, you know it. So
Okay.
whatever you said is right. You know, like the explanation is right. given the explanation you said right now, just think about what's happening. So far I got D, A, B. Any other choices?
I would think B.
You think B?
A, yes, A does not really make so much sense to me. I don't know why, because it's fibers. I don't think, because the cardiac is a cover, and the whole heart needs supply of blood. So why would it be only the pericardium that is supplying? So I'm just thinking B.
B, okay. D, okay. Any other choices, or can I say the answer? Can you say the answer? The answer is D, but I'm going to go one by one, okay? Coronary arteries carry blood to the fibrous pericardium. They are taking the blood to the heart, myocardium. Okay, so that's not right. B, the coronary artery blood flow is fastest when the heart is contracting. What happens when the heart is contracting? The vessels are really constricted. Yes, good job. So there's no blood flowing to the heart. When it is relaxed, that's where the blood dilates. And you explained it so well. I want you to be confident with your answer. So you guys know the idea, right? Like when it's contracting, it's not getting the perfusion. When it is relaxed, that's when the coronary arteries can see blood supply. So then it will be having the blood supply. So the only difference between other organs and the heart is getting the blood when it is relaxed, when the ventricles are relaxed. Okay? And the heart rate does not affect the blood flow of the heart. It does affect the blood flow of the heart. We saw how the heart rate influences the blood flow of the heart. And coronary angiogram identifies anomalies in the blood flow around the heart. That's the right answer, because we use the coronary angiogram as with a small camera. I guess they find it how if there is any anomalies or any blocks. Okay. Are we good? Can I continue with the cardiac muscle cells? Or
So, but why for the angiogram, why is it because it means
That's a very good question, but this is how the questions in your midterm might be. I don't, because I don't set the questions for the midterm. Already Dr. Hannon did it. I'm just here to do it. Yeah, but this is just to make you think. Whenever you do the MCQs, you have to think in an order, like an induction or detection method. Say like you got stuck in one question. You don't know what answer, and even exchange answer. Okay, cardiac muscle. So after the cardiac muscle, we can have a break, can we?
Yes.
Or do you want it now? Okay, you know what? Let's have a break. So cardiomyocytes is the cardiac cells. So, as you can see, the cardiac cell has got a plasma membrane, but we call it as sarcolemma. That's the outer layer. In the cell, we learned that plasma membrane is the outer layer, but the outer layer of the cardiac cell is called sarcolemma. And the cytoplasm of the cardiac cell is called sarcoplasm. Let's say this is the cell. And this cardiac cell, we talked about it last week, that they'll be having lots of mitochondria because it needs lots of energy because it's contracting day and night, so they'll be having lots of mitochondria in it. And there's got a large glycogen bodies because they need lots of energy too. And the special things about the cardiac cells is they have intercalated discs. It's almost similar to the skeletal muscles too. The muscle cells are joined together through intercalated discs. This is one cardiac cell and there's another cardiac cell. They are connected together or bind together through intercalated discs. This intercalated disc has got two different ones called desmosomes. And captured. So the desmosomes are nothing but, imagine you have a zip. so it just joins the two flaps of your shirt. That's how it really holds it together. So it just holds the cell together. Whereas the gap junctions or like channels, they allow ions to go through. For example, sodium or calcium. So if they want calcium to enter, they will be going in and out through these gap junctions. So the intercalated discs has got two, has got desmosomes and gap junctions. Desmosomes are nothing but they keep those cells together because these has to be stronger because when they're contracting, we don't want the cell to just go by. So the desmosomes keep them together and the gap junctions allow the ions to go through. That's how once there is a contraction initiated by a SA node, it just goes through the entire myocardium through the gap junctions because it just goes through them. And we also will be looking at how the action potential goes on. So when we say action potential, how the ions are going from one state to another. So those are the key features of it. So we talked about the mitochondria, social right. And the unique properties of the cardiac muscle cell is it has got automaticity, so nobody has to initiate it. It just automatically goes on and on. And rhythmicity, where rhythmically contracts and relaxes. And conductivity, it conducts the electrical impulses. And contractility, as we talked about, has got good contractile strength. And excitability, that's self-excitable. It has got specialized non-contractile cells which initiate the action potentials. So it doesn't need any nerves to come in and release acetylcholine's. It's not like the skeletal muscles, it is self-excitable, which we will be learning about in a minute. So those are the key properties of the cardiac muscle cells. This is just a brief introduction, so we will go in that. Okay. This one, this is really, really important table. How to say it? This is really important. If I were you, I would be adding a star to the table. I'm sure that's in your handout, right?
Yeah.
It's in your handout. Okay, I'll spend some time on this table. Let's say, okay, so let's see the difference between the skeletal cells, smooth, and the cardiac cells, okay? So under a microscope, the skeletal cell would be looking striated, whereas the smooth would be really smooth, and the cardiac would be striated. When we say striated, you see these ones, you see the lines, that's called striated, so that's how it's going to look like. And fiber arrangement, we have sarcomeres. I'll be explaining what is sarcomere. And the smooth muscle doesn't have a sarcomere, and the cardiac has got a sarcomere. So location, you know the skeletal muscles are attached to the bones. The smooth muscles, you see it in the digestive tracts where they are hollow and they are smooth, right? And the sphincters, that's where you see the smooth muscles. Cardiac muscle, as the name implies, we see it in the heart. And the location, tissue morphology, skeletal muscles are multinucleated, large and cylindrical fibers, whereas the smooth are uninucleated, small spindle-shaped fibers, whereas the cardiac muscle is uninucleated, short and branching. So you see this one is multinucleated, whereas the cardiac is uninucleated. This is large, that's short. This is cylindrical fibers, those are branching fibers. And internal structure, they call the T-tubule, sarcoplasmic reticulum. So is the cardiac muscles, but there's no T-tubules or sarcoplasmic reticulum in the smooth. It might sound gibberish, but I'm going to explain what those mean. Okay. Fiber proteins, we have actin, myosin, troponin, tropomyosin, and same with the cardiac muscles. But here, the smooth, we have only actin, myosin, and tropomyosin. There's no troponin. And the control is with the calcium and troponin, fiber dependent on one another, and calcium and sarcoplasmic reticulum. So is with the cardiac muscle, but we have fibers electrically linked via gap junctions, and calcium from extracellular fluid and sarcoplasmic reticulum will be entering. I will be explaining it how that is happening. So it will make much more sense after we discuss about how these things are happening. And with the smooth muscles has got calcium and calcium, some fibers electrically linked, and it has got calcium from ECF and sarcoplasmic reticulum. Contraction speed is fastest, slowest, and intermediate, right? And then contraction force of single fiber twitch is not graded, and graded. Let's say, I don't know if this is exact, but once upon a time, there was a question. There was a tabular column between skeletal muscles and the cardiac muscles. So one is fast, one is slow, right? But the students are confused because it's intermediate. When you compare between 3, that's intermediate, and this is fast, and that's slow. But when the comparison is between these two, the skeletal and the cardiac muscles, this is fast and that's slow. But I don't remember this was like 5-6 years ago. And contraction force of single fiber twitch, not graded, initiation of contraction, it requires ACH as a chemical signal, whereas the cardiac is autorhythmic because it initiates its own contraction. Neural control is somatic neuron because for the skeletal muscles we have the peripheral nerves, and the smooth muscles is autonomic nerves, and the cardiac is autonomic nerves. Hormonal influence, none, but there is multiple hormones involved in the smooth muscles, and for this one is epinephrine. Oh, so I was right. I was a star. Okay, so the picture might be so complex, so I'm just going to draw a simple picture which might make a little more sense. Okay, so we said the cardiac cell has got single nucleus. This is short, but this is, I just proved wrong, but it's actually branched on. So outer layer sarcolemma and then sarcoplasm. Apart from, in addition to the organelles what we learned in the cell, this cardiac muscle cell has got sarcoplasmic reticulum. And myofibrils. And T-tubules. I'll explain what are these concepts here. So let's start with the myofibrils. So the myofibrils is the chain of sarcomeres. So when we say sarcomere, is the smallest structure of the myofilaments. Okay? You see that? From here to another Z line is the sarcomere. It is the smallest unit of the muscle fiber. So let's say this is the Z line. So from one Z line to another Z line is the sarcomere, which is the smallest unit of the muscle fiber. So this Z line has got the intercalated discs. Okay? So intercalated disc has got desmosomes and gap junctions, so it will keep them together. As you can see, they are all attached. So it will be continuation from one Z line, see the another muscle fiber is continuing. So this myofibrils are nothing but a tube of sarcomeres. So this is myofibril, and this unit is the sarcomere. The myofibrils are like a train. So it has got lots of compartments. One compartment is the sarcomere. Okay. Is that clear so far? Okay. And sarcoplasmic reticulum is like a sleeve. Imagine you have a sleeve and it goes on top of your head. That's how the sarcoplasmic reticulum will be covering the myofibrils. And you will see why they are doing that, because they are so important in giving out lots of calcium releasing, or they have the T-tubules, all this. And the other important thing is the myofibrils has got microfilaments. I know too many words are coming your way, but I can go over it all the day. So myofibrils has got myofilaments, got actin and myosin. You remember that? Good. Myosin is the big filament, and what is thick filament? Thick filament is myosin. Thin filament is actin. Is there a way to remember this? If I'm going to ask you what is thick filament after the class, you'll be able to remember it. Myosin is actin. Thick is myosin, thin is actin. Okay? So in the picture, let's see. Okay, you can see the myosin here. All the dark bands are the myosin. The light blue lines, I don't know whether you can see these thin lines here, they are the thin filaments. These thick and thin filaments are super important because they are going to slide against each other. That is going to give the contraction and relaxation. So that's why we are talking about this actin and myosin. So I'm going to go over it before I go into that. So the cells has got myofibers. The myofibers are nothing but the muscle fiber. The muscle fiber has got two filaments, myofilaments, actin and myosin. Actin is a thin filament and myosin is a thick filament. They just alternate each other in the picture. Okay? And then we will be talking about this Z disc. The Z disc is nothing but here, the sarcomeres. I mean, like sarcomeres from Z line to Z line is sarcomere. This Z line at the end of the word sarcomere is where the interconnected discs are. That's called Z line or Z disc. And you see this M line is the midline of this sarcomere. So M is for middle, okay? That's M line. Is it clear so far?
Yeah.
Okay. And then there is, so there is an I band. So the I band is between this. The I band is only looking at the from the thin filament here to a thin filament there, and this A band is all about this. What is this? Thin filament. Maybe I'll have another picture to show a different one. So this is much more clear, right? So the I band is nothing but where these thin filaments are, where the actin filaments are, and the A band is between from one meiosis to another one. So it completely covers the meiosis area, and the center band is the H zone where the contraction you're going to measure it, because when they contract, they are not shortening. Remember, they don't shorten. Instead, they only slide. So when they slide, you see like, oh, they are contracting, but they are not shortening in their size. When we think about contraction, we think it's gonna, the muscles are shrinking. They're not shrinking, they're just sliding under each other. That makes the illusion that they are actually contracting. They're just pulled together. So let's say this is the actin and myosin. When they are activated, they just go under like that. So the distance is shorter between those ones. And then when they are relaxed. So that's exactly how they contract and relax. So how would you measure it? That's why they have these zones. In the midline, all these actin and myosins are going to come together. This is the midline. So the midline is going to shorten, and the head zone is going to be shortened because they are just sliding like a robot. So that's how they measure. Okay, this is contraction. Okay, this is relaxation. Right?
Excuse me?
Yeah.
Could you go over the M line again, please?
The M line is in the middle of these ones. I'm just going to draw the rest of the picture. We have the sarcoplasmic reticulum. Okay, so we talked about the sarcolemma, and we have the sarcoplasmic reticulum. This is the sarcoplasmic reticulum. envelops the myofibrils like a sleeve. As you can see, the yellow ones, these ones, you can see they are like covering the myofibrils like a sleeve. And they are the continuation of the sarcoma or the sarcoplasm. So they enter into the myofibrils as a T-tubule. So the sarcoplasmic reticulum has got vesicles that store the calcium. So let's say if there is an action potential coming in. So it comes in, then it comes through the T-tubule. This is the T-tubule. Because it looks like a T, right? So it's called T-tubule. So once there is a receptor here, dihydroxyuridine receptor. So the dihydropyridine would be stimulated and it is physically actually linked to a receptor here. It's called rhinodine receptors. So action potential comes through the T-tubule. Through this receptor, dihydropyridine actually sends physical signals to the rhinodine receptors to release the calcium into the system. Into the muscle cells, cardiac muscle cells. What is the role of calcium? So this is really, really interesting. Where I really fascinate about this one. So this actin and myosin, the myosin has got two heads. Like that. Right? And then the actin these actin filaments are hyped by the tropomyosin. And the tropomyosin is bound to the actin by a troponin. So imagine like this. So the actins are covered by the tropomyosin. You know, when we say covered, the actin has got a binding site for the myosin. But it is actually closed in the tropomyosin, we close the binding site on the actin. And so in order to do that, this troponin is actually holding this tropomyosin on the actin. So when the calcium is released, what happens? The calcium goes and attaches to this troponin. Once the calcium is released, it attaches to the troponin. And then it pulls the tropomyosin out, so exposing the binding site of the actin. So once the binding site is open, this myosin head, there's got two heads. One is for the ATP, and this is for the binding site. It gets latched, say like. This is what happens when the contraction happens. So once this is gonna latch, it just crawls in like a robot. It just goes in, and then once the relaxation happens, like the ATP is released, and then the actin and myosin binding cells has to go outward. Then they come back to the normal position. They just crawl in and crawl back, and this is how it happens. So I'm just gonna go over it and all over again. Once the action potential enters into the cell through this T-tubules. There is a receptor called dihydropyridine. I don't think you have to remember this. There is a receptor, so that triggers the rhinodine receptors in the sarcoplasmic reticulum. This initiates the channel, so the calcium is released. Once the calcium is released, it goes and latches onto this troponin. The troponin will be pulling the tropomyosin out so that the actin binding myocytes are open. Once this is open, the myosin goes and attach itself to the actin site. That's the contraction. And then once the contraction happens, these guys will come together towards the midline or the upline. And then once the relaxation happens, they go apart. That's the actin-myosin bridge or the contraction. I think we have a picture. making a little sense because I'm going to go over it all over again one more time. Before that, the sliding theory states that A, actin and myosin filaments shorten and slide past each other. When myofilaments slide past each other, shortening of actin filaments occurs. When filaments slide past each other, shortening of myosin filaments occurs. Actin and myofilaments do not shorten, they slide past each other. What is the answer?
D.
Oh. Okay, so I'm making sense, thank you. I was so worried because I don't need to confuse you guys. So it doesn't shorten, so they just slide past each other. Okay, so that's exactly what I do. So we have this Z disc. The Z disc is this one that is related to there, where there is the intercalated discs, where the desmosomes and cap junctions are there. From one Z disc to another Z disc is the sarcomere. And in the sarcomere, we have the actin and myosin filaments. The red ones, you see, are the actins, and the blue ones are the myosin. So that's how they look when you go in it and see. This is really a sketch to understand how the actin myosin filaments happen. Right? And when they contract, they pull together towards some line. And that's actually the contraction, but they don't shorten, they just pull them together. This picture doesn't have titans. Oh, this has titans. You see this yellow stringy things there? Over there, you see this yellow stringy thing? It's called as titin. Titin. That's the largest protein that is pulling it. This is a very interesting concept. I was really fascinated by it because this titin is actually holding this myosin. This is attached to the myosin, as you can see. This myosin, it keeps it intact. Once it is pulled together, it just goes out and then keeps it in shape. And then once it actually, like a string attached to the myosin. It helps the muscle cell to spring back to its original position after the contraction. So this is one of the strongest and giant, it's called as a giant protein called titin, Titin, the yellow thing. Okay, so this is the myosin head. The myosin head has got two heads, as I was saying. The one is ATP binding, and other one is the head that is getting attached to the actin. So in the actin, from the picture, so this is the actin, the blue, like a great kidney-shaped one. The yellow line is the tropomyosin, and the yellow thing is the troponin. So the troponin would be keeping this tropomyosin on the actin. And the tropomyosin is covering it. Can you see the circle things of the holes on the binding sites are closed by the tropomyosin. Once the calcium gets attached to the troponin actually opens up the tropomyosin, so the binding sites are exposed. Then this head can get attached to the binding site. Okay, so this is muscle relaxed and this is muscle contracted. So when the muscle is relaxed, you can see the space in the eye band. The half of the eye band is relaxed, and you can see the half of the eye band. You can see the head zone has got a wider space now here. But when the muscle is contracted, the actin and myosin is sliding under each other, so the head zone is shortened, the eye zone is shortened. So that's what happens in a contraction. So that's the difference between the contraction and relaxation. They are not shortening, only the space is shortened.
Quick point to address here, just for my own sanity. We can see that in this slide, the H zone, the thicker filaments, are myosins, which are in the color blue, and the actin are shown in the color red here, the thin filaments. But then when we come down to this slide, we can see that the thick filaments are displayed in red, while the thin filaments are displayed in blue. Try not to get confused by the change in color. Look for the thick one and the thin ones. Okay, just addressing that really quickly.
The H zone and the I zone is shortened. Is it clear? any questions, or should I go over it all over again? Do you want me to do one more time? So once the action potential or the signal contraction or the potential relationship comes through, it enters the cell through the T tubule. It goes in. Forget about the receptors. Right. It's a so the action potential enters the T tubule and it triggers the sarcoplasmic reticulum. The sarcoplasmic reticulum is the one is holding all the calcium, stores the calcium in it. So once the sarcoplasmic reticulum is triggered, it releases the calcium. Once the calcium is released, it goes and attaches to the troponin. The troponin is attached to the tropomyosin. It's like a thread-like shape that is covering the actin. So once it is attached to it, it just pulls it. The tropomyosin pulls and exposes the actin binding site. Once the actin binding site is open, this myosin head gets attached to the actin binding site. Okay, this is the contraction. What happens following this is relaxation, right? So this head has got ATP, and it just ATP is an energy, right? So it converts the ATPase, and then it releases the binding between those two, and then comes back to the original position. The titin, which is another protein, the giant protein. This would be stretching. Say like if I'm tied to someone, I'm just going to go towards this way, and I have to come back. That's exactly what the titin is doing to me. The titin will be keeping the shape. So just come back now. So that's what does it. The titin is a protein that helps to maintain the shape of the muscle cell. Is that making sense now? So I would really recommend you folks to go back and read this, and the cardiovascular online module also talk about the same thing. So it's just it would be a nice way to repeat it. Okay. Which of the following is correct? For muscle contraction. Shortening of actin filaments, shortening A, H, and I bands. No change in A band. Sarcomere do not shorten.
C.
What, C?
C.
We all agree on C? The answer is C. Thank you. Okay. Okay, this is interesting. The troponin, we talked about the troponin a lot right now, right? The troponin is on this guy, the actin, and it is holding the tropomyosin and the actin together. So this is where the calcium gets attached, right? So much about the troponin guy. But as you know, the troponin is really important as a cardiac marker. If somebody is going on a blood test, and if there is an elevated troponin, we might say like, oh, he is going on a cardiac condition somehow. Like, why is that? We have three troponins: troponin T, troponin I, and troponin C. Troponin C is where the calcium gets. Yes.
Sorry, she asked question. I think I get it.
Question?
Yes, yes.
Okay. Which of the following is correct for muscle contraction? Shortening of actin filaments. Does the actin filament shorten? No. Okay. Shortening of A, H, and I bands. Do A area shortens? If they say shortening of H and I would say yes. I think this slide has all of the answers. Okay. You see this one? The muscle contraction zone H and I shortens. Only the zone H and I shortens, but not the A. So in one of the choices, it said A, H, and I band shortens. Only H and I shortens, not the A. And then no change in A bands, and sarcomere do not shorten. You're welcome. Okay, coming back to the troponin. So the troponin has got three heads as attachment. Three binding sites. One is T, one is I, one is C. On this C is where the calcium gets attached. And the I is where the ATP is present. And the troponin T is where it's a cardiac marker. Okay, that's where the tropomyosin gets attached. So this is where the calcium gets attached, this is where the tropomyosin gets attached, and this one is where the ATPase, which helps to take away the myosin during the relaxation. So they have their own control system. One has the calcium attachment area, one is attached to the tropomyosin, one is going to be in charge of like, okay, this is relaxation, let me take this out, and so the binding must be closed. So that's what these tropomyosin would be. Troponin has 3 different ones. Among this, which one is a cardiac marker? Yes. Yeah, troponin T is one of the important cardiac markers. And we also use troponin I, but not troponin C. Because troponin C can be increased if there is a skeletal muscle damage. Say I'm working out in the gym, I'm lifting weights, my troponin C might be increased. So that's not exactly a cardiac marker, but now troponin T is used as a cardiac marker. Yes.
Over there in the blue circle,
Yeah.
it says I, and then what's this say underneath?
C, I, no, just this mark.
ATP.
What is ATPase. ATPase.
Oh, ATP. Okay,
Yes.
thank you.
Where was that? So troponin T and troponin I is used as a unique cardiac marker, but not the troponin C. Whereas the CK, what do we know about the CK? And CK and CPK. Interestingly, both are the same. The CK is the term we use here in Canada and US, whereas CPK is the terminology for the same thing used in UK and Australia. So if there is an elevated CK, we think like there is going to be a myocardial infarction or damage to the muscle cells. And there is a particularly an enzyme called CKMB, CKMM, and CKBB. So CKMB is an important biomarker for myocardial infarction or myocarditis, muscular dystrophy, subarachnoid hemorrhage, Duchene's muscular dystrophy, cardiac failures, or shock. But this CKMB does not increase with skeletal muscle damages. Or if someone is having an IM, this CKMB won't be elevated, but CK might be elevated because there is a muscle damage. So any slight muscle damage, CK might be elevated, so you have to look for isoenzyme CKMB to get a clear picture of if there is a myocardial damage or any other system damage. And CKBB is used for brain, and CKMM is for skeletal muscle injuries or skeletal conditions. For the exam purposes, you will be having only normal anatomy questions, so there won't be any pathological issues. So normal anatomy. So this is only for your information, to make it more interesting. So cardiac conduction system. So remember the difference between excitatory cells and muscular cells. Excitatory cells, when we say it's the cardiac muscle cells or self-excitatory, whereas the muscular cells needs the acetylcholine release to get the contraction. The heart muscles is stimulated by nerves and is self-excitable. We have the sympathetic or the vagus nerve to supply this heart muscles, but it doesn't have to, because in one of the book I read, the sympathetic system is, or parasympathetic system in the heart is only going to reduce the heart rate. Say like once the heart is detached from the nerves, it still will be continue to pump because it's self-excitatory, but the heart rate might go 10 beats higher up because this sympathetic and parasympathetic is actually reducing 10 beats lower and controls the heart. But on the other hand, the heart is self-excitable or automaticity, and it contracts as a unit because we have a tight desmosomal junctions. So once the impulses goes into the heart, it spreads across the cardiac muscles and it forms as one unit, and has a long 250 ms of absolute refractory period. We will be talking about what is refractory period in a minute. And cardiac muscle contraction is similar to skeletal muscle contraction, but there are some differences which I want you to remember. The table, right? The table is important. So there are some differences, there are some similarities between these cardiac and skeletal muscles. This is just a summary slide. Do you guys need a 5 minutes break or 10 minutes break before we start the class so that everything settles in, because we are going to go into the pacemaker. When we say pacemaker cells, we talk about the So these non-contractile cells are the ones are called as the pacemaker cells. When we say pacemaker cells, we talk about the cells, a group of cells in the spinal SV node, AV node, one-block His, Purkinje system, all those ones that initiate the action potential and carries the action potential throughout the cardiac muscles to initiate contraction and relaxation. Those ones are called as the pacemaker cells. So these cells initiate action potentials. How do they do it? It's a fabulous way they do it. And they have an unstable resting potential called as pacemaker potential. It's never a flat line. So they are always in the negative and then goes up and down. So that's how beautifully they make this autorhythmicity. And they use calcium rather than sodium. I'm reinforcing this because in skeletal muscles you have the sodium channel and then that releases the acetylcholine that works on the muscarinic receptors and that's how the contraction. But there's calcium involved in it, but there's more of a sodium channel. But here the calcium influx raising the phase of action potential. And 1% of cardiac myocytes have the capacity to generate impulses. So those are the cells and the SA node, AV node, all those ones. So let me explain before we going on to the next slide. I'm going to explain in short how they do it. So let's assume this is the pacemaker cell or the non-contractile cell. This has got two channels. So this is the calcium channel. And this is a sodium channel. So at the resting potential, we have got potassium in it. So the potassium channel closes. So once the potassium channel closes, so this is more negative. So it has to have something positive coming in. So slowly the sodium gets in. It's only trickling inside. It's not rushing into it. So it's a slow sodium gets in into the cell. Okay. Once the sodium starts to get in, it opens up the calcium channel. So the calcium gets into the cell faster. So once the calcium gets into the cell, it initiates the depolarization. We will be using this term more, depolarization and repolarization. Depolarization is nothing but contraction. Repolarization is nothing but relaxation. So once the potassium channel closes, sodium gets in, and then that initiates the calcium to get in. The calcium levels in the cell increases, which would depolarize the cell. Depolarizes the cell. Okay, so once the contraction has happened, what has to happen following contraction? Repolarization, right? So the reverse is going to happen. So the calcium levels are going to go low, and then the potassium gets in. So once the potassium goes back into the cell, then the repolarization happens. Okay? And this is going to go on and on and on and on. That's how we have this constant contraction and relaxation in the cardiac muscles. So you can see the resting membrane potential of this cardiac cells are in minus 60. It's never a flat line. It's in minus 60. So the pacemaker just slows polarization due to both opening of sodium channel and closing of potassium channel. So there is a closed potassium channel and the sodium channel opens. You can see follow the flow chart. Once that happens, the action potential, this is where until here the sodium channel opens. From here, it stimulates the calcium to open up. So once there is an influx of calcium, the number 2 is the depolarization of due to calcium influx. Once the depolarization happens, it has to be followed by calcium coming down, and then the potassium channel opens up, allowing the potassium to get into the cell membrane. So it becomes a negative voltage. So then again, a pacemaker potential comes in, so the potassium closes, sodium opens up, calcium comes in, there's an action potential there, and then the calcium goes down, comes back, and the potassium channel opens, so more potassium goes in, it becomes negative. So this is going to happen on and on and on. So this is auto-generated. So these cells, these non-contractile cells, develop these ones all by themselves. No external inputs allowed, right? They do it all by themselves. They are SA node, AV node, all these ones. They are doing it all by themselves. But what happens if there is going to be a sympathetic response? We saw that sympathetic response also initiates contraction, right? So what happens in that case? So in the same cell, we have this beta-1 adrenergic receptor, and then there is parasympathetic one. So let's say there is a if there is a flight or fight response, so there is a sympathetic response that initiates this beta-1 adrenergic receptors. So what happens is it goes in and triggers this beta-1 adrenergic receptors to open up this calcium channel. They are not really worried about the sodium, so the calcium channel opens up, so more calcium would be there in the cell to initiate more contractions. So once if the parasympathetic kicks in, so you are not frightened anymore, you are relaxed, your midterm exams, you got it, you are panicking, but you read the questions, you know, I can't do this is crazy. So the parasympathetic response is kicking in, your heart rate is going to reduce. How is that doing it? Because the parasympathetic response will be going into this, it releases ACH, acetylcholine, would be coming in, it's going to open up the potassium channel. So the potassium channel is the one that is going to neutralize or to reduce the heart rate. And then once, pardon? Calcium
increases
picks up.
potassium increases.
Got it, fantastic. Thank you. Any questions so far? Yes? No? So we will have another slide about how this is going to work. You will see this. So the green one is the epinephrine.
The red.
The green is acetylcholine. The red is epinephrine, and the control is in black, and green is acetylcholine. So you can see once the epinephrine or the sympathetic is stimulated, you can see the distance between the one beat and another beat is faster and closer, whereas in the control it's spaced in between, whereas in the acetylcholine where the heart rate is spaced because the diastole has to be longer. So that's the difference between when once the sympathetic or when you give an epinephrine to a patient, the heart rate is going to jump up. So that's exactly how it starts. It's not starting at the negative, it starts over there. Immediately influx of calcium, so the action potential shoots up higher and the heart rates are increased due to epinephrine. And the acetylcholine is actually lowering, and as you can see there's water when compared to the control group, so it slows down the heart rate.
So there's something else. Because acetylcholine in the muscles.
In the muscles too, yes.
It's like it gives it the strength to move. Of potassium.
And compared to the rest of the networks, the SA node is here. And that's the bundle of space, and the bundle fraction potential travels through the heart. So starting from the SA node, it travels to the AV node. Before traveling to the AV node, say like imagine that atrium is contracting, so it has to contract the left too. So it has a internodal pathway. So once the action potential is initiated through the internodal pathway, it goes to the left atrium and right atrium, and then it starts the contraction. Once this is there, then it goes to the AV node, and from the AV node it goes into the bundle of space. There will be a 0.1 second delay because imagine cars are coming from 4 lanes and joining 1 lane. So similarly, all these information has to go through the AV node and to the bundle of hills. That takes a little bit time. There's also another reason because in this AV node, in the AV node there's less gap junctions. We learned that the gap junctions is where the ions travel from one cell to another cell. If there is less gap junctions, it's going to take a little time, slower. And then the muscle fibers are a little thinner than thicker in the gap junctions. So that makes it a little delayed too. So, and then there's one clinical significance. When it is delayed, it allows full filling of atrium. So it allows the time to get filled. Once it is filled, then it is going to go back to the bundle. So all these reasons are listed for why there is a delay. Okay? So once it is there, this is the bundle of His. And through the bundle of His, there will be left and the right bundle branch. If there is a block in the left, we call it as the left bundle branch block. And if there is a block on the right, we call it as the right bundle branch block. And then these are the fine fibers that enters into the myocardium is called as a Purkinje fibers. Is that right? So we can also see this in the electromyograph or electrocardiograph, like the P wave and QRS and the T wave. Okay, so from the SA node, it generates impulses, and then from there, it goes to the AV node. There is 0.1 second there, and then from here, it goes to the bundle of this, and then the left and the right on the branch, and then the Purkinje system. Okay, coming to the ECG. So as I said last time, in the last lecture, P wave is nothing but atrial depolarization, in other terms, atrial contraction, give rise to P wave. And the QRS is the ventricular contraction, and the T wave is the ventricular relaxation, in simple terms. I'm going to ask you again, what is A wave? Atrial?
T.
Atrial depolarization. P wave is atrial depolarization. So P wave is atrial depolarization. On the other hand, it's called atrial contraction. And QRS is a ventricular depolarization. And T wave is the repolarization. That's ventricle is relaxing. So what is this PR interval? And what is this ST? And what is this QT? So this QRS takes 0.8 second, and then T wave takes 0.16 seconds because it's ventricular repolarization or relaxation needs time to fill in. So PR interval is 0.16 seconds, which is the beginning of the atrial contraction and beginning of ventricular contraction. So this is where the atrial contracts or atrial excitation. So and the R is where the ventricles are contracting or excited, right? So this PR interval is the atrial contraction to the ventricular contraction. And then there is ST. In the ECG we say there is ST elevated, ST depression. So what is ST? ST is the entire myocardium depolarization. So entire myocardium is depolarized or contracted is the ST segment, whereas the QT from here to here is QT. It starts at the ventricular depolarization where the ventricles are contracted, two ventricles are relaxed. Okay? So P wave is the atrial contraction, QRS is the ventricular contraction, T wave is the ventricular relaxation. So PR interval is from the atrial contraction to the ventricular contraction, whereas the ST segment is the entire myocardium or the ventricles are contracted, whereas the QT is from ventricular contraction to ventricular relaxation. Alright? Due to time, I'm just going to go by faster in a bit. Okay. So again, this is atrial contraction, P wave, and then it goes into the QRS complex. Before that, that's the AV node. This delay is the AV node, and then QRS complex before the endolines, that's where the contraction of the ventricles is happening, and that's exactly the ST segment where the entire ventricles are contracted, and then T wave is the ventricular depolarization, and then this is where the ventricles are completely repolarized. Okay, what P wave represents?
B.
How many A? Lift your hands up. Raise your hands. If it's A, raise your hands. If it's B, raise your hands. Good job. It's B. Okay. So this is contraction. What happens in the contraction we just saw? So there will be influx of calcium, so the sodium channel opens up, and there will be influx of calcium. The calcium channel opens up, and then there will be, once the calcium channel opens up, there will be action potential. Once the action potential is there, there's a contraction happening, and slowly the calcium channel closes and the calcium levels are reduced, and then the potassium channel opens. You see this phase between the contraction and the relaxation is the refractory phase. The refractory phase of a cardiac muscle is larger when compared to the skeletal muscles. You see the skeletal muscles over there and the cardiac muscles here. So you can see there is a tectonic contraction, it just shoots up and shoots down. But whereas in the cardiac muscle, you have this contraction and then it stays a plateau and then relaxes. But we have this time. We need this time in order to fill the atrium of the ventricles, right? So we need the time to fill. So that's why we have this refractory period. Is that clear? Again, I'm going to say the same thing. So this is the physiology of contraction, what we just saw. So in this, initially the sodium channel opens up. Once the channel opens up, it's just going to open up the calcium channel. Once the calcium channel opens up, the action potential raises. And then the plateau is there, so the refractory period is more. Once the calcium channel closes, the calcium depletes inside the cell, whereas the potassium opens up, and then the potassium enters the cell, which decreases the voltage, so that's going to go down. Once again, it's going to open up the sodium. So that's how it goes up and down, right? That's what happens with the contraction and relaxation. Okay, we did. And you know what? I forgot to add one interesting fact. I think we didn't discuss about it. Is the anastomosis of the arteries and veins. I won't take so much of your time. Okay, it's just an interesting fact. In the diabetes people, in people with diabetes, they don't have this collateral circulation. So what happens is, if there is going to be one occlusion in one artery, I said like the other rest of the arteries is going to supply the myocardium, right? How do they do it? It's because you see the tiny capillaries, they will enlarge and they will supply the rest of the myocardium. It takes at least 4 to 6 hours or 8 hours to dilate and supply it. But in diabetes, they don't have this angiotensin. Let me get that name right. It's called anti-angiogenic factors like endostatin or angiostatin. They don't really work in diabetic people. So that's why they have a delayed wound healing. That means they don't develop capillaries. So since they don't develop capillaries, they cannot have an extra circulation. So they have a silent cardiac arrest. Once they get it, they don't even feel it. Before that, they pass away. One of the reasons they don't develop capillaries. But in a people with atherosclerosis, let's say if one of the arteries occluded here, and then the rest of the arteries would start to supply blood for the affected area, and along with the same time, new capillaries would be emerging. They will proliferate new capillaries. So let's say a patient had a myocardial infarction, it was not too bad, but you will start to see after like 8 to 24 hours, the capillaries would be dilated and the myocardium will be having blood supply. And within a month, you won't even see it. There will be lots and lots of capillaries will be supplying for that area. So that will be developing if a person is having an atherosclerosis or a mild MI. Say like a person is having a slow progressive atherosclerosis. If one is occluded, another will be opening up. Once progressively he's having occlusions here, progressively the capillaries will be growing simultaneously. So the person won't be symptomatic. They will be having capillaries growing along the way until the capillaries get occluded by the atherosclerosis. Only then the person will become symptomatic. Isn't that cool how the heart really manages to supply? Thank you. Okay, any questions, folks?